Welcome. Thank you so much for logging in to this. I don't know what number it is, but this next webinar on spine for everyone. That's how I justify my presence in this. Spine for everyone, sponsored by Stryker, and more about that in just a second. It's been a heck of a journey. It's been a heck of a journey, the orthohub thing. It started off, it's only been going 6 months now, and orthohub.xyz, the traffic that's now going through the site is absolutely incredible. We've now got 2,000 unique users attending each of our webinars. The YouTube figures are right there. 300,000 page views so far. 20,000 sessions served on the website. And we've got some really good back catalogue now of webinars, podcasts, etc., which are slowly building up. And they're all, at least we feel they are, great quality, and they're getting repeated views over and over. And it's all free, and it always will be all free. The podcasts have really taken off. If you've not tried See One, Do One, please have a go. They're great fun, and they're hugely popular, as it turns out. If you haven't heard the one, so the one Tim Briggs did, talk about GIRFT and the future of elective orthopedics in the UK, is out now, and that's already like 500 hits in 5 days. It's really absolutely smashing it. On podcasts in total on that thread is now nudging the 9,000 downloads since we went live with them. So they're really hitting. Cash and I were interviewing. We just finished to edit. Cash is working his editorial magic on one we did with Yelena Bogdan just yesterday. She's for those who've not heard of her, she is an emerging talent in the UK and in the US, rather, US orthopedic trauma scene. And she's incredibly prolific on social media. If you are a trainee and got any interest in trauma whatsoever, and you follow Twitter, you've got to follow her. She's like just throwing out tips and tricks on a daily basis, like how to do this, how to do that. She's all over the body, and it's always evidence-based. There's always a little paper attached to the bottom. So if you're not following her, go find her on Twitter. She's awesome. And there's loads of content to come. We've got shoulder instability in 2 weeks. We're talking about controversies in total hip and total knee. We've got a proximal tibia extravaganza. And we're interviewing famous people. We've got loads of educational, maybe I got a bit carried away with that adjective, but but we are, there's lots of what we feel is innovative educational content coming out, which we're really, really excited about. So stay in there. However, as you all know, like running a website and producing content is expensive, and the more you do it, the more it costs. And I can tell you, when the website goes down, it is, you have to get like a boatload of super nerds in to come and fix it. It costs money, and those guys don't come cheap. So we are now getting all of our things sponsored. This one's very kindly sponsored by Stryker Spine. So thank you guys for taking a punt on us and sponsoring this. This is with a caveat. All of our speakers today they're not receiving any money for this. None of them are paid. And the OrthoHub outfit, we are not for profit. So the money that we're getting from industry to support these educational things is being driven back in to support the website and basically drive development of new educational stuff that's coming out. And there's a shed load coming out. We're doing podcasts every couple of weeks now. We had a bit of a break in the summer, but now it's really going crazy, and there's loads of stuff coming out. So enough about that. But again, thank you, Stryker, for sponsoring this. Today, Spines for Everyone. And I'd just like to introduce first of all, thank you very much to our 4 awesome faculty for coming in today. And I'd just like to start with introducing my buddy and my colleague, Alex Montgomery, otherwise known as Monty. Monty, thank you very much for chairing this session and leading it, because I have got no credibility in this field whatsoever. I'm here purely to ask stupid questions that people on the Q&A are too embarrassed to ask. Monty.
Awesome. If you could put my video on. Thanks, Pete. Yeah, so today is about spine for everyone. So what does that mean? Well, it's for mainly trainees, and a lot of you will be doing the dreaded spine clinic and seeing all those all over body back pains and how we differentiate between those we are going to operate on and those we don't. Those of you who might be doing surgery, you might be on call, you might be dealing with quarter equina, and of course the FRCS as well. And of course, there'll be some of you, a few of you that want to do spinal surgery. And my opinion on that is really until you understand the basics of back and leg pain and how we manage it non-operatively and operatively, you can't really make good, complex decisions yourself. So we're very fortunate. We've got 3 awesome speakers today. We're going to go through the basics of spine in terms of back pain and leg pain, quarter equina and trauma. So on that note, I'm going to hand it over to my friend and colleague, Dave Cummings, for the first talk on back pain.
Okay, perfect. Thank you very much, Monty. So I think I got the short straw here to talk about back pain because it's one of the most difficult areas. Obviously, there's a large volume of patients and there's a high level of litigation with regards to complications that happen when things are missed. So I'm not going to go through, I'm a spinal surgeon in the East of England. I've done spines for 9 years as a consultant, and I have other roles you can see there. So this is the simple part. So we all know what back pain is. It's coming from the spine. It's coming from the lumbar spine most of the time. The problem is it can originate from lots of different places. So it can come from the paraspinal muscles. Some back pain can be from nerve compression, particularly in spinal stenosis. It can come from the joints, the facet joints. It can come from the discs themselves, if you believe in discogenic pain. Now, there's lots of people who get sudden back pain, so there's acute back pain, and then we all know there's a large number of patients with chronic back pain out there, which in some ways causes a lot of problems who come in and out of hospital. And again, the pain can radiate around different places. And the pain can be a dull ache, it can be sharp, it can be piercing, burning, and all of these characteristics are quite important because they can tell you where the pain's coming from. So what I'm going to do is take you through a little bit of a journey through, as a trainee particularly, what should we do about patients being admitted as an emergency. We all know, and I remember as an orthopedic trainee, that there was nothing worse than admitting a back pain to a consultant who doesn't like spines. And we've all had it, and we all get abused for it. And I think the problem is, certainly as a spinal surgeon now, a lot of these patients don't get the respect that they deserve, and therefore we miss things. We skim over sometimes. So when we're doing an assessment, they're as important as any other patient. They might not be a trauma patient with bits of bone smashed up, but quite often they have pathology. And the ones who don't have pathology still have needs. So we need to respect that and assess them properly. So the first thing we need to do is rule out red flags. So I'm sure you're all aware of red flags. We can go through them later, but that's the most important thing, first of all. Also, rule out other pathologies. So the young mechanical person is likely to be a back pain. But if you've got somebody in their 70s, 80s, actually think about other things. Emergency departments nowadays are under a lot of pressure. They're very good at putting patients of pushing them through the system, putting them on the ward. I've had patients with multiple medical problems on our ward who have back pain, and actually the back pain was caused by other problems, which I'll go through in another slide. You want to rule out neurological problems. The worst case scenario is you don't want a patient who's a back pain who actually has cauda equina and you've missed it. That's going to be a bit of a nightmare. If the patient does just have back pain after assessing them, then actually the majority of these patients, if you give them good analgesics, you reassure them, they get some physiotherapy, they can be discharged. But I would warn, the biggest litigation cases out there is when people have missed cauda equina. So make sure you clearly document that you've discussed and assessed properly, and also that you've warned the patient of cauda equina symptoms. And if they develop that, then they should return immediately and give them safety netting. Some places have cards and various other information they give to patients. But Hani's going to go into that further. And then the other thing is signpost these patients onto physiotherapy, onto other services. Some of these patients, the chronic ones particularly, will bounce back in again and again. So find them another place to be if there's nothing else that we can do for them. Make sure they have a link into the pain team or into physiotherapy. So what do we want to ask? So really, the main thing, first of all, is you want to know where the symptoms are and what they are. Are they just in the back? Are there any symptoms down the legs? Are there any neurological symptoms? Have they got weakness, numbness, tingling? Have they had any recent trauma? Now, in some elderly patients, this might be minor trauma, which has resulted in an osteoporotic fracture. Or if they've got other pathologies, such as metastatic disease, a small amount of trauma, again, might cause significant problems. It's useful to know whether this is acute, or whether it's acute on chronic, or whether it's chronic pain. Some of these patients, as I've said, are very chronic with their back pains, are known to pain services, and actually we can manage them in a very different way. And it's useful to go back through the notes and see if you have an electronic system of notes. It's good to have a quick look, see if they're known to people. It gives you information before you talk to the patient. And then you're looking for their past history. Have they got a previous history of cancer? And this can be many years ago now. So some of these patients will have had cancer 10 years ago who now develop metastatic disease, especially prostate cancer, breast cancer. Have they had previous surgery? Have they had any recent infections? So again, elderly patients particularly might have had sepsis, they might have had urinary infections, partially treated, they might have an underlying discitis. Steroid usage, so you're looking for that osteoporotic fracture, and again, they may be more prone to infections. And drug abuse, so there might be things around infections again, TB, and etc. So you want to talk about when is their pain bad? Is it just when they mobilize? Is it a mechanical weight-bearing pain? Or do they have pain at all times? Do they have pain at night, which is obviously a red flag? The other thing from a neurological point of view, people with sciatica quite often have pain worse when they've been lying down overnight. The morning is bad when you get up and start moving around, and then it tends to wear off a little bit. Is the pain sudden onset? Is there anything that exacerbates it? You need to go through bladder, bowel symptoms. Sexual dysfunction is something which we very rarely ask, but a lot of patients with large disc prolapses and pending cauda equina have sexual dysfunction. Where does that pain go? Is it just in the back? Is it go down into the loin? Is it a renal pain? Is it actually the spine at all? Or does it go down the leg? And what is their sensation? Do they have normal sensation for all their dermatomes? So you need to, we skim over these patients a lot of time. If you miss something, the first thing a lawyer will do is go and look at your assessment. Make sure you don't just write normal neurological assessment. Write out the dermatomes, the myotomes, the reflexes. Make sure you do a proper assessment. Have they got any signs of nerve compression? Have they got a static stretch test? Does the pain go down to an L5 distribution, an S1 distribution? You should do a PR examination. So when doing that, you need to do anal tone. You need to do proper sensation of all the sacral nerve roots. And if you're worried, then do a pre and post void bladder scan. So every patient I get referred with a query cauda equina, I ask people to do a bladder scan before the person passes water, and again, make sure they're emptying their bladder properly. So what other causes have I had in the last year? So I've had patients with renal colic. I've had patients with urinary infections and pyelonephritis. I've had a pancreatitis. I've had cholecystitis. And I've had a gentleman who was known to have an aortic aneurysm that was leaking, placed in my ward. So this is where it's really important that, especially in the elderly patients, look for other causes, look for other reasons, and make sure the patient's under the right specialty. Once a patient ends up in a ward, they get stuck in a ward. Make sure the right patient is in the right place. So what are the spinal causes? So a lot of these patients will just have an acute exacerbation of back pain. There'll be mechanical pain, sudden onset, really deep ache in their back. And a lot of these patients will describe pain radiating into their upper thighs. They get a lot of muscle spasm. They feel their legs give way sometimes. And that's all to do with that muscle tension and spasm. Neurological causes, so sciatica should be fairly obvious. But some people with spinal stenosis, some elderly patients find it difficult to describe their symptoms. But sometimes they've got a really deep ache in their back and into their buttocks. And that may be a really severe spinal stenosis. Trauma, it may be low energy trauma in some of these patients. But again, there should be a specific incident that's occurred. Usually there's been a small trip or lifting something heavy. There's nothing worse than elderly patients in the emergency department's done an x-ray of their whole spine and said, we've got an osteoporotic fracture. A lot of those are old, they're not new fractures. Have they got infection? So discitis is becoming increasingly common. Osteomyelitis is not so common. And then is there tumours? So a primary tumour is very, very rare, but obviously it does exist. And metastatic disease, much, much more common. I see a lot of myeloma patients, and we think patients of myeloma may only be people in their 60s, 70s. I've seen people in their 30s and 40s with myeloma. So how do you make a diagnosis? Let's go back to basic principles. A good history and examination will get you the answer a lot of the time and will point you in the direction of what tests to do. Blood tests. So if you do a routine set of blood screens, full blood count using the CRP, ESR, you'll pick up a lot of things. You'll pick up those infections. You'll quite often pick up a myeloma with an ESR. You'll pick up things that are there. X-rays, unless there's recent trauma, I don't think there's a good reason for doing an X-ray. So you can quite often avoid that. CT again, I don't think it's that helpful. And really, you're looking towards an MRI scan if you really need to. So when should you do an MRI? We can MRI everybody, but obviously that's just unrealistic a lot of time. So certainly if there's red flags, raised inflammatory markers, recent trauma that you're worried about, any abnormal neurology which you're worried about, concerned about, then the patient's going to end up with an MRI scan if they've been admitted to hospital. Otherwise, you're going to miss things or they're going to bounce back in again. And multiple admissions. I learned at a very young age as an orthopaedic registrar, not just in spines, but anything. If a patient keeps coming back, actually within days, there's something not right. And I've had a patient recently who, again, was in their 50s, bounced back in 5 or 6 times to the emergency department and had metastatic disease, no previous history of cancer. So MRI scans, what you tell the patient is really important. Do not just read the report to them. You need to understand what you're looking at. We all get disc degeneration. It doesn't mean we all get back pain. So it's really important how we put these things across to patients and actually how we reassure patients a lot of time. If there's no nerve compression, no sinister pathology, they've got a bit of degeneration, tell them their scan for their age is normal. Actually, we can treat their back pain, you'll get better. This doesn't mean you're going to have back pain forever. So what the words that we use are really important, and people remember it, and people remember words like crumbling spines, disc degeneration, that they feel terrible. So what we say is really, really important. So a couple of cases, this is one where this patient, it's really bad central back pain, bilateral buttock pain, intermittent urinary symptoms. You can clearly show she's got a big disc, and Hanny will talk about this later, but this lady didn't describe bilateral sciatica. She described really bad back and buttock pain and a couple of episodes of urinary dribbling. This patient, 45-year-old gentleman, back pain, feeling generally just not quite well, with some sweats on and off, but nothing terrible. His temperature's maybe 37.5, 37.8. He's got some increased uptake around his L5-S1 end plates here, and he's got some inflammatory tissue around on that axial scan, which is, he's got a low-grade infection which has been grumbling along for a while. This chap had some oral antibiotics for infections, which was, the GP didn't know where it was, and he'd had on and off antibiotics over a 3-month period for a week at a time. This patient, you look at this scan, 76-year-old lady, night pain, back pain, leg pain. As soon as she stands up, she's in agony. She's had a history of lung cancer 10 years ago. And actually, if you look at the first sagittal scan on the left, which is the T2 scan, it looks pretty normal, and it's easy to miss what's going on here. If you look at the right-hand scan, if you look at the L5 vertebral body, there's something just not quite right there. If you look at the axials now, the right L5 pedicle on the left hand in the T2 image shows you a mass within that pedicle in destruction. And you can see it on the right hand one, the T1 scan, much better. So this lady's got metastatic disease 10 years down the line. Now, interestingly, we operated on her and she didn't have lung cancer. So lung cancer, you'd think survival poor, but actually they thought she was cured. She actually had breast cancer now. So there's a new cancer further down the line. Whereas this gentleman's 40 years old, had back pain for a long time, bilateral buttock pain. He remembers having pain on and off this whole time. He's got a pars defect. This is something which is obviously not concerning acutely. We can tell him about his diagnosis. We can tell him that most people can manage this conservatively, and that actually we could arrange for him to be seen by a physio and referred back in through a proper triage pathway if need be. So most of the things, apart from that last case, if you look back at them, they all had red flags. So the age and the history are the most important thing. A good examination is important, but all the cases before that last one had a malignancy, one had cauda symptoms, so I'd be worried about, and one had an infection. And so they are all red flags that we should pick up on. So you're absolutely right. So the management of mechanical back pain, if the scans are performed, take the patient through the images, explain it to them, reassure them about normal age-related changes. Don't mention those really bad words that they get hung up on. Physiotherapy to mobilize them, good analgesics. So don't use opiates. Opiates are bad for patients. They cause constipation. Again, a lot of antineuropathics cause urinary symptoms as well. So use simple things, low-dose diazepam for muscle spasm, amitriptyline if need be, if they need sleep. There's nothing worse than having bad pain and not sleeping, and anti-inflammatories with PPI cover. So that's your acute part. Now we move on to your nightmare of the spinal clinic. So every trainee's nightmare is a spinal clinic. Overrun clinics with back pain. So the first thing I'm going to say is, if you take up spines, convince everybody that you should run a proper triage service. You should only be seeing things that you can help. Most back pain can be treated by physios. So you need a good relationship with physiotherapists, a good relationship with pain specialists, and most patients should have other pathologies if you're going to see them. So my rule on back pain, there comes a point where people need to be pulled out at the top. We can't see everybody as consultants and as surgeons. Most of them don't need us. So we need somebody upstream to take the ones we don't need out, and we can help the ones left behind. This is your 2.1 billion cost to the NHS in 2008. It's far more than this. Back pain costs more than anything, and it's an absolute nightmare. But I think a lot of it is because we poorly treat these patients, and we can help them a lot better than we do now. This is the queue of people coming to see me in clinic, and I might see most of them, but actually, you know what? The vast majority of them don't ever need to see me. If you want to know what that is, that's all the people trying to get into America. I'm sure they're now turning the other way now that Trump's had COVID. So what do you do in your outpatient clinic? So what are the symptoms? So is that patient there with mechanical back pain, or have they got neurological symptoms? Is it a recent trauma? Is there something that's upset it? Again, is it acute? Is it chronic or acute on chronic? Are they known to the pain team already? Have they already been and seen people? Is there people we need to talk to about? Have they had treatments before? And again, have they got any previous history of anything that you're concerned about? So where is the back pain? What's the nature of it? What makes it better? Where does it radiate to? Is it actually a radicular pain? Is it a stenosis? Do they have a background inflammatory condition? Is this a rheumatological condition? Or do they need to see a rheumatologist rather than a surgeon? And remember to examine the hip. Think about pelvic pathology as well, particularly in ladies. So there's other things which can cause problems, and abdominal pathology. So when you examine them, look for deformity. Remember, think about your scoliosis as well as your kyphosis. So think about both planes. Think about your neurological assessment. Look at their hip, knee, look at leg length discrepancies, which may be causing problems. Think about your vascular assessment as well. So I've seen patients who have had severe vascular claudication who actually have had back pain as well as bilateral leg pain. And where's the pain? Is it worse in flexion? Is it worse when they load it anteriorly? Or is it worse in extension, particularly extension rotation? People talk about facet type pain in particular groups of patients. So imaging. So if you're going to do x-rays in clinic, do a standing x-ray. And actually quite often you need to do a standing x-ray of the whole spine. You want to know what that sagittal and coronal balance looks like to see whether they're off balance or what's there. MRI scan of back pain when required. So not everybody with back pain needs an MRI. If they come to you as a consultant, then you may need to do it. CT scans I really reserve for surgical planning, or if I'm worried about a pars defect, which you can't always see in an MRI scan. SPECT CTs had a bigger role. and discography. So I do discography. I do it as a diagnostic test. Not everybody believes in it. So can we help? Who can we help with surgery? So to me, there's instability type things. So people, when you're decompressing the spine for nerve problems, actually a lot of these patients have back pain as well. So spondylolisthesis degenerative is probably the most common things I see. Also lytic spondylolisthesis for when you have a pars defect. So some younger children, you may repair the pars directly, but usually by the time you see most of these people, they're in their 30s and 40s, and we're looking to do a fusion if we need to in those patients. If you've got a single level black disc, then actually they don't tend to do so well for fusion surgery, but post-discectomy patients in that group tend to. And then you're looking at people with deformities as well, and your spinal stenotics. So this is a CT of a pars defect. It's chronic, has been there for a long time, and this is the L5S1 level, and this is somebody who's probably got some back pain and has got may have some L5 pain as well from that foramen. So that's somebody who I may decide to operate on, and there's different ways of doing it. So surgeons do anterior or posterior or both. There's no right or wrong. It depends on the surgical decision. So this is an example of a project case, which is not unusual. So this patient had a previous L5S1 discectomy for cauda equina, got better from a cauda equina point of view, had ongoing severe back pain, which just wasn't getting better, been under the pain team, no radicular pain, multiple injections, not getting better. So we took the decision to fuse the patient. She had a standalone anterior fusion, actually did very well for a period of time, but then she started to return with severe lower back pain again. She'd always engaged in exercise and Pilates, analgesics. She had spinal injections again under the pain team. But now the L5S1 level on a CT is fused, but the right-hand image is an MRI, is a CT SPECT scan showing increased uptake at L4-5. Now this leaves a difficult situation because she's got multi-level disc degeneration. But what do we do now? So some surgeons will fuse 4-5. Some people just say there's nothing I can do. Some people will just say send to the pain clinic. So it's a difficult decision. Back pain is a lot more difficult to treat surgically than radicular or nerve pain. So here's another case, a 30-year-old lady with low back pain, really bad back pain, had lots of physiotherapy. The problem with this lady is she's already had a discectomy at 2 levels, at L3-4 and L4-5, complicated by an infection. And now she's developed a slight deformity and she's really struggling with her pain. She's been to a pain specialist, she's paid for extensive physiotherapy and rehabilitation, and she just wants an answer. She's miserable. So this again is a very difficult situation to deal with. And thank you very much. Any questions?
Thanks, David. That was awesome. I mean, actually, what stood out for me there was the fact that there is a big differentiation between clinic and A&E. So when you're in clinic, you're expecting someone with musculoskeletal problem. In A&E, the back pain could be anything, couldn't it? I mean, aortic aneurysm is pretty scary. The other thing also is that MRI scans, obviously we don't scan everyone that has back pain. After about 8 weeks, most of them should have resolved their back pain. So really a lot of the reason we're doing it is to rule out something nasty and not to tell them they've got multiple level disc degeneration. There's no radiation with MRI scan. So that's great talk, thank you. There's a few questions and I have a few other questions. So from the audience, you mentioned residual post-voiding. One question from anonymous person was, at what point would you be worried? How many mils residual would you be concerned? Or
so there's lots of people who have written various papers on this, and Hani might cover this in his talk from cauda equina, but I know that Nottingham published a paper recently, and some people are talking about less than 250 or 200. I have to be honest, I'm a bit stricter than that. I think that if you're a young person, you should empty your bladder pretty much. So I'm looking for less than 100 mils in most patients. And I think that's safer, to be honest.
Yeah, no, I'd agree with that. And also, just briefly, I know we've talked about this a lot before, but another person asked about discography. And I know we could go on for ages, but just really briefly, when would you use discography?
So, I mean, I may be an outlier. There's various proposals about this. I was very much brought up by a surgeon who used to do discography, which was provocative. So what he would do was you would take the patient to theatre, you'd put a needle in the disc and then you would inject some dye into the disc to make sure you're in the nucleus. And then you'd inject very small volumes of fluid to check the pressure, and you'd wake the patient up during this procedure. Now, my experience was they all screamed at you. So the provocative, and also you're meant to use a normal level as a test level, which I think is bad. So what I use it for is a patient who has gone through a whole pain management process, single level disc, degenerate disc, who maybe has got a positive or increased uptake of a SPECT CT or a post-discectomy type patient who I see as a good candidate for fusion. I would do what I call an intradiscal injection. So I put a needle into the disc, put contrast in to prove I'm in the nucleus, put a little bit of steroid and local anesthetic in. I would then do medial branch blocks at the same level. So I blocked the whole level in one go. And then I tell the patient to keep a diary. If they have a very good pain relief for a good period of time, then I think they're a good candidate for fusion.
Yeah, sure. And Hani, I mean, people come to the clinic with back pain. I mean, do we, if the right candidate turns up, do we operate on them straight away? I mean, is there anything else we should do beforehand?
I mean, it really depends on what your pre-clinic setup is like. If you have, as David described, a very good sort of physiotherapy service and rehab service and pain clinicians involved and so on and so forth before they arrive at the spine orthopedic clinic, then it may be that they've already exhausted all conservative options before coming to you. So it may be that you have a setup like that, but most of the time that's not the case. And actually there's quite a lot that you can do or you can suggest before, doing an operation. And anyway, it's much better with this kind of thing to know patients a bit, and you want to see them twice or three times before you think about an operation anyway, because you need to get to know people with this kind of problem, because there's a lot, it's very multifactorial as to what's generating their back pain.
Can I ask a question about SPECT CT? It seems like it's become a new wonder investigation for a lot of specialties. How much radiation is involved in a SPECT CT of a lumbar spine? Is that a big slug or not as much as it sounds?
It's quite a big slug.
Yeah, I mean, it's a good question. There are actually different types. So I know, like for instance, the Wellington Hospital has a SPECT CT, and I know that dosage is higher than other places, but then it's more accurate. But yeah, I don't know exactly how much, and people talk about 50 times more than X-ray or whatever, but it's a big slugger. It's a second line kind of investigation if you haven't managed to find the cause.
So I guess my question would be, is there any role for this in the kind of acute setting, in the like patients come in, and they've been admitted by the team on call overnight, and there's not much on, they've done an MRI, it doesn't show much, and maybe they've even done an X-ray and there's not much there, and is that something that you would, is there any role for it in that setting?
No, I don't think so.
No, it's a preoperative decision-making tool.
Yeah,
I would say for all the acute patients, if they're not moving, you get the MR to reassure the patient so you can get them out. But I think it's then from there, if they're a frequent flyer, you need to just build in that safety netting as to, a lot of these patients want to know where to go to, if you see what I mean. And the best way to stop them rebounding back in is to say, here's somewhere you can go. And that might be a spinal clinic, it might be a pain clinic, or it might be physio. But you need to give them an outlet, if you see what I mean.
Yeah, I love it.
Lionel, there's an interesting question to be posed here. It says, can cervical thoracic cord compression mimic cord equina syndrome? So you've got someone who's got, say, incontinence of bladder, and the lumbar MRI is normal. Can a massive disc at T8 or C7 cause incontinence of urine and bowel?
It'd be a really unusual presentation, wouldn't it? I mean, a thoracic compressive lesion, you'd expect to get upper motor neuron type signs in your lower limbs. I have to say, isolated urinary dysfunction or autonomic dysfunction consequent to cord compression would be quite unusual. I think the more worrying version of cord equina is where you have a lumbosacral, an L5-S1 disc herniation that migrates caudally behind the S1 vertebra. and you can get cauda compression affecting the bowel and bladder, but with no leg pain, and sometimes with very little back pain. So I think it'd be unusual for cervicothoracic pathology to mimic cauda equina. Usually patients present with spasticity and features of myelopathy, but beware the cauda equina without leg pain, where the lumbosacral disc has herniated caudally is the nasty one.
Yeah, I mean, nerves are funny things, right? You can get weakness in the leg without leg pain. You can get pain without numbness, whatever. So it can present in many ways. Just a very last quick question, just slightly political one, on back to SPECT scans. There's a slight impression, maybe from those of us that are in London and the rest of you are on the outskirts or outside, that SPECT scans aren't as available in outside London as much. Is that true, Randall, or is that a myth?
I can only comment on our unit, and we've had one for several years. We perhaps have only started to look at reasons for using it, trying to localize pain pathologies, and particularly in the spine. And we found it pretty useful as an augment where MRI and CT just aren't good enough at localizing the pain. But yeah, we've had one at Norwich for a while. I don't know what the situation is like in the rest of the country, but that's a good question. Maybe that's a poll that Mike Barrett can do for us.
David, are you your BAS members? Do they complain of not being able to get CT specs? Is that a thing?
We haven't had that. I think what it usually comes down to is whether you've got a radiologist who's interested in it. So usually you need to find a radiologist. Most hospitals now have access to it somewhere, but it's just whether you've got a radiologist who wants an interest MSK wise. So you sort of need to push somebody in the right direction.
Yeah. Okay, great.
Awesome.
All right, take us on.
Yeah, brilliant. So our next speaker is Hani Anwar from Stanmore, and he's going to talk about leg pain. Slightly easier topic than back pain, slightly easier to treat. So I'll hand it over to him.
Okay, thank you very much, Monty. And I think, so I'm talking about nerve entrapment. And what we'll do is we will try and run through a bit of anatomy and all the basics and things which, are, so there's a poll on the screen that's just appeared, so you feel free to answer that. Yeah, all the sort of normal questions that you might have in general orthopedics about how we talk about spines with respect to nerves. So we'll talk about nerves, what happens to them, how you should manage things if there's a problem with a nerve, and cauda equina syndrome. We're not really going to talk that much about spinal cord compression. So a nerve root, you probably hear about nerve roots, nerve root compression, all this kind of stuff. Remember, it's a bundle, it's a nerve fiber bundle which is coming off the spinal cord, which then in the cervical and thoracic spine goes out of the spine and joins via a ganglion to another nerve fiber bundle, which goes off to the target organ, whether it be skin or muscle or whatever, and then lower motor neurons. Okay, we know that the spinal cord ends 2/3 of the way down the L1 vertebra on average in most people. And then after that, we've got the cauda equina below that, which are lower motor neurons. And then they go out, and there's also still another ganglion before they get to the legs. So you'll also hear people talking about traversing nerve roots and exiting nerve roots, and they're numbered, right? So in the neck, you have the vertebrae, which are called C1 to C7. You've got 7 cervical vertebrae, 12 thoracic, and 5 lumbar. Now, the nerve roots are named after the pedicle that they're close to. So in the thoracic and lumbar spine, they run right under the pedicle of their adjacent vertebra. So the L5 nerve goes under the pedicle of the L5 vertebra, and it's quite closely associated to it. In the neck, it's the other way around. The nerve root runs just on top of the pedicle of the associated vertebra. So the C7 nerve is sitting right on top of the pedicle of C7 vertebra. And because of that, you've got a slight nomenclature issue, because the C1 nerve goes on top of the C1 sort of lateral mass, which means C7 is above C7, but T1 goes under the T1 pedicle. So you've got a gap between C7 and T1, pedicles, if that makes sense. And for those of you that it doesn't, you just have to think about it for a bit. Anyway, that's where the C8 nerve, so that's why you got an extra one. And it's because of that, the way that they call it. Now, the traversing nerve and the exiting nerve is really relating to the lumbar spine. In the lumbar spine, you've got a sort of an area inside the spinal canal, which is a bit to the side. And that's the traversing nerve is there, and it crosses the disc above the pedicle that it's going to exit via, if you see what I mean. So the traversing nerve at the L4-5 disc is the L5 nerve, which then goes under the L5 pedicle. So I hope that all makes perfect sense now. So that's why we talk about traversing nerves and exiting nerves. And if it's easier to remember, it's all that, you know, the nerve that's most likely to be compressed at any given level is the lower number. So C4-5, the nerve is likely to be affected is C5. In fact, it's the only one which is likely to be affected, C5. In the lumbar spine at L4-5, it's probably L5. But if it's a far lateral disc, it could be L4 because the exiting nerve runs over the side, which is L4, runs over the side of the L4-5 disc. Hope that's perfectly clear now. So that's why we talk about central disc problems or central canal problems, which may affect all of the nerves, lateral recess problems, which tend to affect the traversing nerve, foraminal problems or far lateral problems, which can affect the exiting nerve. But all of them are lower motor neuron issues. Now, when a nerve's trapped, you get some symptoms in the distribution that nerve goes, okay, which we're going to come on to. But the assumption can't be made that that's definitely disc, for example, that is putting pressure on that, although the probability is very high that it's going to be something like disc or osteophyte or something, spondylosis, depending on age and depending on the medical history of the patient. But we should always remember, as David has already said, that there's other things that can affect the spine, not just disc problems. And so therefore, it can be other pathology within the spine, trauma, tumor, infection, commonly would be the ones you'd think of, that can also be putting pressure on a nerve. So radicular pain, so pain coming out in the distribution of a nerve, and symptoms, or neurological symptoms in that distribution, signifying a nerve entrapment, is often due to degenerative disease or acute disc prolapse or something like that, but can be other pathology. And so you have to have an open mind when you're assessing these patients and make sure that you take a thorough history and examine them. And often, it's difficult to tell clinically and to differentiate these things clinically, but you can say probability-wise, it's most likely to be degenerative. What's the presentation of a person with a nerve entrapment syndrome, right? Nerve is pinched in the spine, in the neck typically, or the lower back, although it can happen in the thoracic spine. And when that nerve's pinched, it often causes a lot of pain. So I tell you for sure that nerve pain is extremely severe, okay? Part of some of the operations that I would do normally require me to sacrifice nerve roots, say, for example, tumor operations or something like that. And a patient can be deeply anesthetized and have had no problem with me cutting the bone, taking away bits of muscle or whatever else. Nothing happens to their heart rate, nothing happens to their blood pressure. As soon as you get to the nerve, if you do anything to it, heart rate goes up, blood pressure goes up, and the anesthetist will notice it every time. And sometimes quite severely, actually, a big change in their physiology when you do something to the nerve, despite the fact that everything else didn't affect them at all. So nerve pain is really painful, even for a person who's under anesthetic, right? So if that's the case, and often that pain is in the distribution of the nerve. So acute pressure on a nerve often causes severe pain, and it can also cause pain in the spine. Now, the distribution of that pain is quite variable. Okay, so for example, C5-6 nerve root impingement will usually, so a disc at C5-6, you usually get the C6 nerve, and you'd think about pain, which is coming down the lateral aspect of the arm, the sort of radial aspect of the forearm, and maybe some numbness or radiation into the index finger and thumb. That would be the typical distribution. But it's not always like that. It could be that they get a lot of pain in the neck and in the shoulder, and also in the periscapular region, which is a common area of radiation for this kind of pain. And likewise, in the lower back, it may be typically going to the buttock, down the back of the leg, and all the way to the ankle and foot. But sometimes they just get buttock pain, and sometimes they actually just get calf pain, and it's variable. So don't be surprised because the pain isn't exactly in the distribution that you think it should be. There's stretch signs that you can test both in the upper and lower limbs, and you should learn them, and that will help to see whether this is likely to be a nerve pain. What can also help you is if there's any dysfunction of the nerve. So one thing is pain, the other is dysfunction. The main two things that you check with respect to dysfunction are sensation and power, but there'll be potentially dysfunction in other things too, but those are the ones you tend to check. Don't forget Corday-Quiner syndrome. The Asia score is a standardized scoring system for neurological assessment in spinal cord injury, and that's what it was designed for. But I think it's quite useful because it gives you a standardized way of examining the neurological system. And it means that if you, for example, say, well, I think there's a C6 problem or whatever it may be, if you're doing it according to the Asia protocol, then the expected neurological findings will be consistent from one person to another. However, having said that, I think you need to be very cautious with this because it's not true that C7 operates only your elbow extensors, right? That's false. And there's people who could have a C7, a problem with their C7 nerve who's still got good elbow extension. And there's people who have a problem with C6 who get some weakness of elbow extension. So there's variability, and there's lots of other muscles which are affected, but at least it allows us to communicate in a way which is consistent. I think when you're documenting neurological examination, try and include the movement. So you say, elbow flexion, wrist extension, elbow extension, finger abduction, whatever the tests are that you actually did. If you document them and then say what the power was, that's more useful than necessarily just saying a nerve root level. So if you say, if you go C5, grade 5, C6, grade 5, that's less useful than saying what test you actually did, in my opinion, if you want to be accurate. But because these are the muscles that C7 may contribute to. So it's a lot more than, just elbow extension. Upper motor neurons. So so far we've been talking about lower motor neurons. So these are nerve roots, essentially, you could think of them as. Upper motor neurons are different. So upper motor neurons are, part of the central nervous system. Compression of upper motor neurons is not painful, generally speaking. So they don't present with pain syndrome. So I think one of the things which mentioned was, could Corday-Quiner syndrome actually be, a higher lesion? Well, higher lesions can cause bowel and bladder disruption, but they still clinically don't really present as Corday-Quiner syndrome. That would be a different presentation generally with myelopathy, and it may well not be painful. So what we need to think about with the spinal cord is to be able to differentiate between a spinal cord lesion and a lower motor neuron problem. So lower motor neuron problems cause weakness, muscle atrophy, fibrillations, wasting, hypotonia, low tone, hyporeflexia, reduction in reflexes, in the amplitude of reflexes. Upper motor neuron signs, you've got positive and negative signs. Positive signs are things like hyperreflexia, the clona, spasticity, and so on. And upper motor neuroscience, which are negative, are things like loss of coordination, loss of balance, weakness, and so on. So clinically, they're really quite distinct. And the only time that you run into trouble differentiating the two is when somebody's got both, which sometimes happens. And then you've got upper and lower motor neuron signs. But I wouldn't really worry about that. I think if you've got upper motor neuron signs, then that's something you actually have to take quite seriously and will point you above, the lower back. These are the special tests, Romberg's, hyperflexia, Clonus, Hoffman's. If you check these, you're not going to miss anything. And I think it's always worth actually at least doing plantar reflexes when you even if they presented with a lower limb problem, or with lower back pain, do something to check their long tracts, because a lot of people with degenerative change in their lower back, they've got it in the neck as well. And actually, if they're weak, you scan the lower back and you say, oh, it's normal, but actually they've got weakness in their legs and they've got problems because of something in the neck. It's a shame to miss that, and you should be able to pick it up clinically. And always think about the adjacent joints, hips, shoulders, sacroiliac joints. Think about vascular. I think it's very important in these patients to document, even if it's just a line, no evidence of peripheral vascular disease or whatever it may be. Even if you've just looked at the skin or checked their pulses, it's important because, we've just raised this issue at AAA, but people can have peripheral vascular disease, just giving them leg pain. And very common to get trochanteric bursitis causing leg pain. So it's worth pressing on their hip. Most of them get better with conservative treatment. If that doesn't work, we do epidural. Sometimes we do decompressions, and that's basically the algorithm. So most of them are going to start off with rehabilitation and painkillers if they don't have progressive neurological deficit or Cauda-Equina syndrome. So those are the indications in my mind: progressive motor dysfunction and Cauda-Equina syndrome. Then you're thinking, actually, this patient may need to be, you need to accelerate this process towards surgery rather than, sticking with conservative treatment. So Cauda-Equina syndrome, as I mentioned, lower 2/3 of the L1 vertebra and down is basically the Cauda-Equina. And these are lower motor neurons which come from the bottom of the spinal cord. The sacral nerve roots are right in the center of the Cauda-Equina. And if you start, and the sacral nerve roots are the ones which operate the bowel and bladder. So if they start to become dysfunctional, it usually means that you've got quite large disc prolapse, or you've got something which is causing severe stenosis. And also, if they become dysfunctional, they often don't recover, and they get progressively worse. So trying to do something about it before it becomes a permanent problem is important. The red flags, according to the NICE guidelines, are bilateral sciatica, progressive neurological deficit of the legs, difficulty with micturition or impaired sensation when passing urine, rectal fullness, perianal or genital sensory loss, laxi-anal sphincter. So I think what's really important is to think about what those sacral nerve roots are supposed to be doing. So they operate sexual function, bladder, and bowel. And they operate sensation in that regard, and also motor function in terms of the anal and urinary sphincters. And so are those working or not? That's what you're trying to work out. And in what, to what degree are they dysfunctional if they are, okay? And that if you keep that in your mind when you're assessing these patients, you will be able to, manage them correctly. Altered sensation. So we sort of divide this into two different categories. Cauda-Equina syndrome, which is incomplete. So it's an incomplete neurological injury. And these guys have got a chance of significant recovery, remembering that the severity of the neurological injury at the time of surgery is probably the best predictor of what their final function will be like. So the worse you let them get, the worse they'll be in the end. And they'll have some mild symptoms. They might have presented with a single episode of urinary incontinence, or some altered urinary sensation. They say, oh, I hear it when I pass urine, I don't feel it properly. I hear it before I actually know that I'm passing urine, or they leak a bit, or whatever. These are symptoms that you shouldn't ignore in a patient with significant back pain, especially if they've got bilateral leg pain or whatever. You need to think about, what's the diagnosis? This is a new symptom. What's the diagnosis then? You can't just say, well, they've started leaking urine, but I've done a PR and they had normal anal tone, so it's all right. No, if there's no explanation for why they've suddenly started having, leaking urine, then you need to have an explanation before you carry on and you discharge them. So think about that. Trigone sensation is catheter tug sensation, basically. Trigone is sort of the bit at the base of the bladder with the sphincters there. So if you pull on that, then they should be able to feel that. So that's, potentially, if they have been catheterized, an alternative test to see if they've still got catheter sensation. That's a helpful sign. And they should still have it if it's incomplete. Cauda-equina syndrome retention is when they've already got urinary retention, okay? And often then they're presenting with overflowing continence. So the bladder fills and fills and fills, and then eventually it can't fill anymore and they start leaking and they're incontinent. This is a bad situation, especially if they've got fecal incontinence as well. This is suggesting that they've got a near complete cauda-equina injury or complete, in which case the chance of recovery is significantly lower than if they're still incomplete. Now, that doesn't mean we don't decompress them urgently, but the chance of them having recovery is lower. And actually, in some ways, it's less of an emergency because the chance of them recovering is lower. But I think, it's very difficult clinically to say for sure whether they're, complete or whether they've still got some function. So therefore, I think you've got to decompress them urgently regardless. But these patients got, saddle paresthesia and all the usual cauda-equina signs. And actually, it's kind of too late. They've presented at a point where it's going to be difficult to reverse these symptoms. So you've got to do the saddle examination. You do your sort of discrimination of light and sharp touch S2 to S5. You do your digital rectal examination, even though the NICE guidelines now say that that's not necessarily needed. I think there was some questions about the post-void residual. The reason why I've put greater than 100 mils residual, I think you have to, as David said earlier, a young person, more than 100 mils residual is an unusual outcome. And it's a more sensitive test than saying 200 mils. Most of the literature now is opting to go for 200 mils and say if you've got more than that, then you probably need a scan. I think if you're a young person, you've got back pain and leg pain, you've had some kind of urinary symptoms and you've got more than 100 mils residual, that's more than enough, regardless of your PR examination to warrant an urgent MRI scan. And certainly if you've got more than 200 mils, I think you need a scan. And what that means is that your bladder is not emptying properly. So it's dysfunction. It's basically you're retaining urine. Okay, so that's what that's signifying. And so I don't want to labor the point here, but if a patient presents and says, I'm finding it difficult to pass urine, I've got new back pain, whether they've got leg pain or not, or they've had an episode of incontinence, you need to work out why they're having difficulty passing urine. Have they got a big prostate? Have they got a UTI? Are they on morphine? Is it pain inhibition? Is it because they've got high dose pregabalin, prescribed, and then they've got urinary retention because of that? What is the actual diagnosis? And you can't. I see this time and time again. People doing a PR examination saying normal sensation, normal tone, no evidence of cauda-equina syndrome, home, but they're presenting with urinary symptoms. And I think you have to be more discriminative than to just say normal PR examination. I'm happy with that. Because if they do develop full-blown cauda-equina syndrome in the next 24, 48 hours, and the original presenting complaint for your consultation was episode of urinary incontinence, query cause, or, patients finding it difficult to pass urine or whatever, or, it doesn't matter that the PR was normal. That was the time that they needed to be decompressed. And so, this can help you to try to differentiate and always think, what's the diagnosis? If I'm going to discharge this patient, I need to be very clear in the notes what I think is going on with them in terms of their bowel and bladder function. So essentially, if you think, I think this patient might need an MRI scan, then the patient needs an MRI scan, right? Just get it. Yeah, as I mentioned, pain-related urinary retention, opiates, constipation, prostate issues, urinary tract infections, all of these things can give you urinary symptoms. There are alternative reasons. You know, most of the patients you scan are going to have no evidence of chordae equina compression, right? If every single patient you scan has a massive disc, then you probably missed some, right? So, you know, the proportion, chordae equina syndrome is actually quite a rare diagnosis. So you would expect that a proportion of the time you'd be scanning somebody who didn't have chordae equina syndrome, who was presenting with new urinary symptoms. So that's fine. That doesn't mean you've done the wrong thing, that, oh, it's a waste of time, scanned another person who didn't have chordae equina syndrome. That's fine. As long as you had a good justification to do it, then get the scan, and then there'll be a few people who will actually have a massive disc, or they'll have something going on, you pick them up early. And so, you know, these diagnoses that I put here, these are exclusion diagnosis. You know, you've checked everything out, you know, you've done your scan, it's not there. Okay, maybe it's pain inhibition, or maybe it's because they've got a big prostate or whatever. So in summary, radiculopathy is very painful. They may have motor or sensory dysfunction. Remember, with motor dysfunction, it's MRC grading. MRC grading is 1 to 5. That grading is not out of 5. I'll just bring this up because it's one of my, it's, you know, this is a categorical system. 2 out of 5 is not half of 4 out of 5 in this. So there's no, so it's actually just MRC grading 1, 2, 3, 4, or 5. It could be A, B, C, D, E. It's a description. So MRC grading 1 to 5. Epidural injections for those people who fail conservative management, and surgery if they've got progressive neurological deficit or if they failed conservative treatment and injections. And warn every patient with, you know, discs of chordae equina syndrome. Chordae equina syndrome is a rare diagnosis. 50% are going to be incomplete. Decompress them early, it makes a huge difference. They need to be picked up. 50% are already going to be in retention at presentation. Emergency surgery probably not going to change the outcome significantly, but we still decompress them urgently. It's the better thing to do. Don't be too reassured by your PRs. That's I think the biggest thing. As I said, I've seen it lots of times. People get really reassured. They go, no chordae equina syndrome. Most of the time they're right. Those few ones that aren't are always illegal, you know, go down the legal route. So get an early MRI scan and document everything. Questions?
That's awesome. Thanks, Hani. Great talk there on leg pain. So, I mean, Dave, there's a lot of controversy about injections, and people lump them into, you know, one big category, all the injections. I mean, should we be doing them, or is it just for us to get Ferraris? And also, when would you do an injection for leg pain?
So I think, so I'm not a great fan of repeat injections. I would certainly say that people with acute sciatica are your best group. So if you've had sciatica for, let's suppose in the NHS particularly, they take a while to come to you. But if you've had sciatica for a few months, you're struggling, then a nerve root block, an epidural, whichever you want to call it, is definitely worthwhile. And there's good evidence. I mean, we did a study in Ipswich where our acute sciatics, about 70% of those patients got better when we did the injection. They never came back to see us again. So it's definitely worth it in some people. There's a few who you can repeat it if they've had good improvement and they're just not quite there. But most of the time, if it comes back with a vengeance, then I more push towards moving to a discectomy at that stage if need be.
Brilliant, thanks. Yeah, I mean, for me, I think there's a lot of misunderstanding about injections and their use, and you know, a lot of it is to get you to do the rehab and get you stronger and try and protect your back. So some great questions. I was going to ask Lenel this one anyway. I mean, foot drop, Lenel. I mean, we could sit here, the four of us, talking for about half an hour about this. how long would you watch a foot drop, and does it make a difference if it's painful or not?
Yeah, it certainly does. If patients have radicular pain in association with a foot drop, I'd probably approach it as we would most patients with acute radiculopathy, particularly if their foot drop's getting worse. I think the published literature that's a little bit more interesting is the painless foot drop. All the evidence is that patients will get better, but there is some evidence from Holland that if you decompress people earlier, their leg function seems to recover earlier. But in general, painless foot drop, I don't operate. People with progressive neurological dysfunction, I would operate urgently. So that's my approach to it.
And so say someone has static 3 out of 5 power in their foot.
Yeah, as long as if it's painless, as long as it's not deteriorating, I'll treat them conservatively. If it's painful, I certainly would offer them an operation.
At what particular point?
I'd say I'd treat them exactly like I would an acute radiculopathy. So I'd give them 6 weeks, and if they weren't getting better, offer them an operation.
Yeah.
But I think that's you make a good point. That's a controversial area, how you manage and how you judge progressive neurological dysfunction. One person's grade 3 is a person's grade 2. It's very, very subjective. So I think your assessment is the same assessor should assess the patient. And there's certainly a good rule for operation for progressive neurological dysfunction. But where there's established loss, particularly if they've got a complete foot drop, I have to say I don't operate. What do you do?
Yeah, no, exactly that. I mean, across the, as you know, nationally, I think most of us agree roughly on 6 to 8 weeks. And I know that for our MDTs in different places. If you go internationally, I've done a meeting with Germans and Americans where they can't believe we've waited longer than 4 weeks. And any weakness gets operated on within a few weeks. So I think we like in the UK, we like to give people who could get better on their own, which a lot of them do, a time to get better on their own. And we sort of dive in and operate, when the time is right, but not leaving it too long so that there's irreversible nerve damage. I mean, it might be reversible straight away. But yeah, similarly, painless foot drop is a difficult one. And it's a conversation with the patient. That's the main thing. Pete, yeah.
I'm itching to ask a stupid question. Hani, can you demonstrate on camera what your favorite upper motor neuron sign in the upper limb is?
Yeah, sure. So ONOS, I think, is a really useful test. And it's the one that's been asked in there. So I'll show it to you now. Basically, it is very simple. You extend your hands in front, fingers together, and open and close as quickly as you can. And the patient does it with you. And as you do it, okay, they tend to fatigue and the ulnar 2 digits tend to drift away. Yeah. So if you do that, that's quite an early sign. Okay. So you just keep on going and they start to go like that. Then that's an upper motor neuron test, which is pretty early, actually.
Love it. Love it. And can someone in this room explain to me why you can stick a disc on an L5 nerve root and you can leave it there for 1.5 years and dick around, inject it and like screw around with it and then decompress it and it will come back to life and it'll be fine. And you press on a cauda equina for 5 minutes and it's dead in the water. Why is that? They're both peripheral nerves, right? So why is that one survives and one is dead?
Yeah, I don't know the exact cellular reason for that, but it's just about ability to recover. And it's like...
It doesn't survive. Sorry. Yeah. It doesn't survive, does it, Alex? It doesn't survive. If you've got something on the L5 nerve and you get, say, for example, a foot drop, like what's been discussed, and it's severe compression, if it's complete, it probably won't come back. I mean, it's just like...
I was just going to, I think it's a traumatic event. So if you think about cauda equina, they blow the whole disc out. There's so much force behind it that blows the disc out and squashes the whole cauda equina. Right. Most individual, and this is me sort of, to some extent making up, this is my feeling behind it. It's like most traumatic injuries with regards to fractures and cord injuries. It's that initial severe trauma to it. Right. And whereas if you have a disc prolapse like a L4-5 posterolateral, it gradually bulges out. It doesn't blow itself out completely, if you see what I mean.
Right. So it's just the pressure.
I think so.
Yeah. But actually that leads on to kind of the next question I was going to ask Dave, which is, how long do you wait before you operate? I mean, in my opinion, it really depends on the patient. Is he young and active? Is it an older patient? At what point does the literature say that we might get irreversible nerve damage? When's the point that we should stick the knife in and operate on a leg pain?
So, I think it's really difficult. I don't think there's a definite answer to it. So, like, I get asked, when would you do a cauda equina, for example? Would you do it in the middle of the night? And you know what? My threshold has changed, in all honesty. And also with really bad acute disc. So if somebody comes into me through ED with a big, it's not a cauda equina disc, but a really big disc, rip roaring sciatica, couple of episodes of urinary dribbling, but the disc isn't a cauda equina disc, it's just a big posterolateral disc. I take them out quicker now. I usually intervene a lot quicker than I used to. If I've got somebody who's 30 years old with any symptoms of cauda equina with a big disc, to be honest, I go and take it out now. I think they just do better. But people might disagree, but I'm quite aggressive at it now, to be honest.
But let's say you've got a 35-year-old patient who's been in pain, just leg pain, no cauda equina, no weakness. He's been in leg pain for 6 months. You've tried a few injections. Is that a good time to go in?
Yeah, I'd go in sooner rather than later at that point, because I think there is a degree of chronicity. So they might not develop with permanent neurological dysfunction, but they will end up with some degree of chronic pain. There is the mental aspect to this. You can take the physical element away, but they are mentally damaged. It's miserable having sciatica. So if somebody's not getting better, you want to get in and just deal with it at that point.
Right. Quick last question. There was a question about dynamic MRIs versus the normal static ones, Hani. I mean, I have a view on that. What's your view on, you've got a patient with leg pain, the supine MRI hasn't really shown anything, and you're thinking, well, they might be, compressing the nerve inflection, let's do a flexed MRI. What's your view on those?
So we've done a few different things. We do sometimes a standing MRI scan. We've done flexion extension MRI in a supine position. We've done sitting MRI in the open scanner. I have to say, I've never found a huge difference. And there's a difference in the overall appearance of the spine, but the amount of extra disc bulges that are picked up causing nerve root compression because of a sitting MRI or a flexed MRI compared to a supine one is minimal. And I think there's one that I've had where I thought, yeah, the foraminal stenosis, L4-5, sort of maybe degenerative spondy, something like that, but no foraminal. And I thought, actually in the standing position, the lateral recesses look worse and the foramini look worse. So I sort of convinced myself to do it. I don't know. I don't think it added that much in the end. That patient didn't do fantastically well. So that's my opinion. I don't know if other people have had a different opinion, but a different experience, but I haven't found a huge difference.
Yeah, no, I'd agree. I've rarely found it to, make a difference because they're not actually statically compressed. They might be on general movements, but I've rarely found it made a difference in what I would do. We should probably move on to our last speaker. We've got Lenore Lutchman from Norwich. He's going to talk to us about spinal trauma. Over to you, Lenore.
You. So I'd like to thank OrthoHub for inviting me to talk. It's a great privilege and an honor. I think the reason I got this gig is because both Hani Anwar and Monty worked for a while on the spinal unit at Norwich. I'm pleased to report that most of the litigation related to their stays with us is now being resolved. There might be one or two loose ones that we need to talk about afterwards, boys. The reason we become orthopedic surgeons is because we like fixing things. We like the gratification of making people better and seeing them walk out of hospital. And I'd like Mike, if he could, to do a survey of the trainees. How many of you want to be spine surgeons? And I'd be interested to know that at the end. I'm going to talk about the spine fractures as you'd imagine one would in an anatomical way. We're going to start with the neck. We're going to talk about the thoracic spine and thoracolumbar junction. And finally, we're going to talk a bit about the lumbosacral junction. And I'm going to show you that spine surgery is orthopedic surgery. And at the end of the survey, I want to have convinced 10% of you to change from being soft tissue knee surgeons to being spine surgeons. We're going to look at the role of plane radiography in assessing the cervical spine in trauma, and we're going to look at peg fractures in the elderly and in the young. My clinical case that I submitted is of a cervical fracture dislocation type injury. So when I answer that on orthohub, I'll deal with this particular group because it's quite an interesting subgroup. So we're not going to talk about that so much tonight. I'm going to talk about the thoracolumbar junction. The survey's come up, so I'm going to say yes, please. Minimize that. We're going to talk about the thoracolumbar junction in the elderly and in the young. And one of the recurrent themes of my talk is going to be, and Pete will agree with this fully, when it comes to trauma, it's all about the energy of the injury, and it's all about the demographic of the patient that you're dealing with. High energy versus low energy, the young, robust patient versus the elderly, fragile patient. So let's start by talking about a fairly sort of normal case. Every spine surgeon has one of these in his or her carousel of slides. This is a 73-year-old lady who's admitted under the physicians. She's had a low energy fall in the kitchen and she presents with neck pain. She has plain radiography of the cervical spine. And all you can ever tell from these x-rays is that these people have arthritis. They are of no use in patients with degenerative disease. She's mobilized on the ward, despite the fact that she's got ongoing neck pain, but the physicians are reassured that the radiologist has reported the x-rays as normal. She becomes acutely quadriplegic because she has an unstable cervical spine, and she requires emergent spinal surgery, from which she has some recovery, but certainly not great recovery. Everybody talks about the Canadian C-spine rules, and I want you to look at this slide very carefully for your trainee. Everybody talks about the indications for radiography. Note that in that box in the top left-hand corner, this rule says that if you're over 65, mandatory radiography is mandatory. If you have a dangerous mechanism or neurology, radiography is mandatory. And if you read the paper, you'll see that angst-spond or rheumatoid arthritis or distracting injuries in high energy trauma are exclusion factors. So actually, as an orthopedic trainee or a registrar going down to ED, nearly everybody you see needs imaging of the spine if you're asked to assess that patient. And if you read the paper carefully, CT in this study was at the discretion of the doctor assessing the patient. So what I would conclude and what I want you to take away, and I'd be interested to see what my fellow panelists think, I don't think there's an indication at all for cervical plane radiography in the assessment of trauma. If a patient has high energy trauma and they have neck pain, they need a CT scan. If they have high energy trauma and they have a distracting injury, even if they don't have neck pain, they need a CT scan. And I used to think that that was an old wives' tale, but I have seen it as a consultant where cervical spinal fractures can be missed in patients with clavicular injuries. In all people, if they have low energy trauma and they have neck pain, they need a CT scan. An X-ray is useless. And in a patient with angst-spond with any cervical pain following trauma, they need a CT scan. So if you take one message from this talk, one message, and you're an orthopedic trainee, if you are asked to clear the cervical spine in a patient on ITU or HDU or in A&E, if imaging of the cervical spine is thought to be necessary, get a CT. Don't get X-rays. I'd be interested to see what the other panelists think when I finish. So in answer to my first question, what's the role of plane radiography? None. Let's go on to peg fractures. As an orthopedic trainer, you spend a lot of your time doing this operation. This is a common fracture pattern in elderly people with poor quality bone, which results from low energy trauma. The aim of the treatment is to treat pain and to allow rehabilitation. This is a common low energy trauma in elderly people with osteoporotic, poor quality bone. The aim of treatment is to allow early mobilization and to treat their pain. And in my opinion, and again, I'd be interested to see what my fellow panelists think, I don't treat these people operatively. The other analogy that I want the trainees to remember is neck fractures are entirely analogous in the elderly. Peg fractures are entirely analogous to a broken hip. This paper from the Journal of American Gerontology Society shows that if you have a peg fracture and you don't have a core injury, your risk of mortality at 1 year is almost identical to breaking your hip. Think about C2 fractures in the elderly as you would broken hips in older people. There is no role for halo vest immobilization in the elderly with peg fractures. And in this paper from the Journal of the Trauma of Acute Care Surgery, a halo vest was an independent predictor of mortality in older patients treated for peg fractures. Surgery comes up. You might work in a unit, in a major trauma center or a spine unit where surgeons are very aggressive when it comes to operative treatment. If you look at the literature, the paper from the Journal of Bone and Joint Surgery from 2016 showed that the 1 year mortality in the operated cohort was significantly better. But my criticism of this type of work is that surgeons are highly selective. There is a huge amount of bias in selection of patients who are appropriate for surgery. And in my opinion, despite these papers, I still treat these patients non-operatively, unless there's a clear reason not to. So for the elderly, in my opinion, odontoid peg fractures can be regarded to have a high mortality comparable to breaking your hip. They should not be treated with halos. And in general, non-operative treatment is to be favored. Let's talk about the young hip fracture. If this 50-year-old comes in with a broken hip, with a minimally displaced or even a significantly displaced intracapsular fracture of the hip, our treatment is to reduce and to fix. This is a high energy trauma. This is not low energy trauma, because to break your bone when you're 50 probably requires a significant force. And I submit to you that an odontoid peg fracture in a young person is usually as a consequence of high energy trauma, a road traffic accident or such. And the approach to treatment is different. This is a slipped upper femoral epiphysis, courtesy of Mr. Sangarajka, one of my pediatric colleagues. Spinal trauma is orthopedics. From day one, the thing you're taught to do is to place a screw in bone along a path. And you cannot perforate the cartilage or you'll get necrosis, chondronecrosis. And you have to learn to put the guide wires and the screws in the right place. And for this type of fracture, in a young patient with high energy trauma, that's exactly what you have to do. You have to reduce the fracture. You have to get a guide wire in the right place. You cannot perforate the far cortex too far, otherwise you're in the brainstem, and you need to get that screw straight down the fairway. This is a DHS. This is a cannulated hip screw. This is a pinning for SUFI. This is what we're taught to do. And it's just an extrapolation. It's just picking the right indication. High energy trauma in a young patient with a displaced odontoid peg fracture. This is probably a fairly uncommon scenario, but it's something that we do from time to time. And the last thing I would say about peg fractures in the old and young is you should, at least at 2 weeks and possibly at 6 weeks, get an x-ray to show that the thing's not displaced. This is one of my patients who presented in her 50s. When she was 20, she broke her neck. She was treated with bed rest, and she presented in her 50s with a very odd symptom. When she turned her head to the right, she got pins and needles and paralysis down into her arms and legs. And she had cord compression from an unrecognized non-union of the odontoid peg. Monitor these patients at 2 and 6 weeks and make sure the thing doesn't displace. This patient required stabilization and decompression. So in summary of odontoid peg fractures in the young, it's due to high energy trauma. The approach is entirely different. Consider halo stabilization or fixation. And whatever you do, monitor the patient clinically and radiologically until you're satisfied that the fracture is not displacing anymore. That's what I want to say about cervical fractures. I keep coming back to these weird long bone pictures because I want to show the trainees that spine surgery is orthopedics. This, as you can see, is a comminuted diaphyseal fracture of the mid shaft of the femur with a spiral component. This has been stabilized with a bridging plate, and it's been very nicely reduced. That's a good orthopedic operation. I don't know why they didn't nail it, but they didn't. It might have been open, maybe. This is a comminuted thoracolumbar fracture in a 20-year-old young man who climbed up a tree. He was fishing and he was trying to spot fish, and he fell out of the tree, probably from a height of about 40 or 50 feet. That's the kind of thing we get up to in Norfolk. And at first glance, this bears little resemblance to that diaphyseal femoral fracture. If you look at this 3D reconstruction, though, I submit to you that that is entirely analogous to high energy trauma through the spinal column, resulting in what effectively is a comminuted spiral fracture of the spinal column. And this is treated just like you would the diaphyseal femoral fracture, with internal fixation using a bridging system and basically pedicle screws and rods. It's entirely analogous. Spinal surgery is orthopedics. So for thoracic spinal fractures, what I want you to remember is they're like diaphyseal fractures, and we use an internal X-fix, much like you would for a diaphyseal femoral fracture. Coming on to the thoracolumbar junction, this is a very common pattern of injury, and you'll see lots of these as an orthopedic registrar. We want to consider them in two groups, in the elderly and in the young. In the elderly, this is a common fracture. As you know, it's one of the three fragility fractures associated with osteoporosis, the other two being the distal radius and the hip. Treat them with analgesia, mobilize them, get some standing x-rays. Dynamic x-rays in this group are very important because supine x-rays may underestimate the degree of kyphosis. Some patients want a brace for psychological reasons, but all the evidence is that braces make little or no difference. And the only thing I would say to you is follow them up clinically and radiologically, just like your peg fractures. Make sure that over the course of 4 to 6 weeks, the thing doesn't displace and become more kyphotic, and that the patients remain neurologically stable. Make sure the GP start them on bisphosphonates, and there is a role for cement augmentation in patients who don't get better. But in general, most of these things can be treated non-operatively. In this case, the patient has an MRI scan which shows a large vertebral cleft. So that fracture is represented by the fluid in the vertebral body. And the next slide is an interesting one. It makes the point that I want to lead on to. Here is a periprosthetic femoral fracture distal to a femoral stem, which is well cemented. These slides are courtesy my colleague, Ben Davis, and I hasten to add, he was presented this to revise it. This is not an operation that was done at Norwich. And look at the proximal fixation. There are two cortices. There is one screw proximal to the fracture. And not surprisingly, the construct fails. Here is a thoracolumbar fracture in an elderly patient. We've put one screw above and one screw below, and the construct fails. My point in this slide is stabilizing the spine is much like plating a fracture. You've got to have adequate fixation proximally and distally to the fracture in order to get fracture control. So in the elderly, a conservative management is, in my opinion, to be preferred. monitor the patient, and there's a small subset that need vertebroplasty. Let's look at thoracolumbar junction fractures in the young. And I love this slide. I dug out the original Chance paper. GQ Chance was a radiologist in Derby, and in 1948 in the British Journal of Radiology published this seminal paper on Chance fracture, and he described a flexion injury, and it has a characteristic pattern. Bear in mind, he didn't have CT, all he had was plain radiographs, but it's a bony disruption, which is quite characteristic, and it still bears his name. And this is what we see on CT scan. You can see in that L1 vertebra, that horizontal cleavage through the bone, typical of the Chance's fracture. And the MRI scan shows you how it involves the posterior elements. So Chance's fracture is a high energy trauma fracture, flexion distraction type injuries at the thoracolumbar junction, resulting in a split through the bone involving the anterior, middle, and sometimes the posterior column. The other beast that you need to be aware of is a very different one to the one that we saw in the elderly. This is a high energy trauma in a 20-year-old, major injury, massive comminution and compression of the conus. And the takeaway message from this slide for the trainees is this is quite dramatic, and it's not hard to work out this person's going to have conus injury. But sometimes L1 fractures or thoracolumbar fractures in general can result in a degree of retropulsion, which damages the conus, but the patient doesn't have lower limb neurological dysfunction. So in patients with thoracolumbar fractures, always do a PR examination and examine perianal sensibility and anal tone and their bladder sensation, because they can have a lower motor neuron lesion affecting the conus with sparing of the lower limbs. Always think about it. This fracture needs reconstruction, and however you do it, it requires using screws to anchor above and below the fracture, and we use ligamentotaxis. You can see on that picture the screws, the Chance pins, are divergent because the spine is kyphotic. What we do is we pivot the Chance pins and we make them convergent, and we've corrected the deformity by reversing the kyphosis and by distraction. And thanks for Bob Crawford for these slides. Now we can do this percutaneously, and I know that Monty and the team at Royal London have a great deal of experience in percutaneous stabilization of fractures, which is something that I sometimes do with my colleagues at Norwich as well. So in the young, this is a high energy injury pattern. The aim is to stabilize the spine and have a high index of suspicion for a conus injury. Finally, lumbosacral fractures are, in my practice at Norwich, very rare, but I suspect Monty and Pete must have their fair share of unhappy Londoners launching themselves off of tall buildings. Norwich isn't spoiled for choice when it comes to tall buildings. So this young man jumped off the 5th floor, I think, of a parking lot in Norwich. And you can see the fracture dislocation of the thoracolumbar spine. My colleague Andy Cook and Ben Davis, who's a trauma surgeon, and I reconstructed this. The key to this, and what I wanted to, the key to this slide is this is a multidisciplinary approach. I know we use that expression a lot in medicine. This needs a pelvic and acetabular surgeon, it needs spine surgeons, and it probably needs a plastic surgeon and a colorectal surgeon. Our patient had a defunctioning colostomy. He had a Moral Lavelle lesion over his sacrum as a consequence of the trauma and needed plastic surgical input. But this needs a joint up multidisciplinary team. And I'm lucky to have Mr. Davis and Mr. Cook and great plastic surgical colleagues at Norwich. And we put this guy back together best as we could. I've seen him for follow-up recently. He's had sacroiliac screws fixation by Ben, and Andy and I we did some iliac bolts and lumbar screws to stabilize it. The key to this injury, high energy trauma, multidisciplinary approach. Rare, but I'd be interested to see what Pete and Monty's experience is. High energy, multidisciplinary care. And I want to conclude with this slide. This is a wrist fracture that's malunited. There is residual dorsal angulation. So how do we treat this in orthopedics? Well, we break it and we reset it. We do a corrective osteotomy. These pictures are courtesy David Yo, who's an excellent hand surgeon at Norwich. He does an osteotomy, fixes the implant to the distal fragment, and by using cantilever bending, reduces the plate onto the proximal fragment and achieves a beautiful correction of the bone. What would we do with a malunited thoracolumbar fracture? Spinal surgery is orthopedic surgery. The spinal cord is compressed, but what you do is you remove the fractured bone, you do a corrective osteotomy, you fix the pedicle screws in proximal to the fractured vertebra, and you use cantilever forces to reduce the deformity and fix the fracture distally. It's exactly the same as a dorsal corrective osteotomy, a volar corrective osteotomy for a distal radial malunion. So, my concluding slides: spinal trauma surgery is orthopedic surgery. And I hasten to add, not neurosurgery. Approach a spinal fracture like a familiar long bone fracture. Think about reducing the fracture, holding it in position, and rehabilitating the patient. There are a few caveats which I'll explore when we do our clinical case. And in conclusion, I'd like to thank Ben, David, Anish, Bob Crawford, and again, really thanks to OrthoHub for inviting me. It's a great honor.
Awesome, Lionel. Thanks so much. Spines is orthopedics. That should be in the title. Yeah, I mean, Lionel, you're a closet general orthopod, right?
I am.
You know, you're just hiding away being a spine surgeon. Brilliant. Thanks very much. With regards to your question of spinal pelvic fractures, yeah. So people tell you we see a lot of them. We've published it in several places. Ibrahim Al-Daily wrote it all up. So we've got a very large series. I don't know where it is now. Must be at 50 or 60 cases. And most of the time we get away with percutaneous kind of fixation. That case was kind of extreme. So yeah, that was a good case. Hani, tell me, you've got your average kind of registrar or fellow who's been asked to see a spine fracture in A&E. What's the best way of communicating to his consultant the severity of the fracture? Because it often can be a little bit irritating on the other end of the phone, can't it? When you're just told, oh, it's a bit fractured, there's bits of bone here and there. But what's the best way for them to describe and communicate a fracture?
Well, there's two different ways, really. One is to classify it, and you can use a classification system which you both agree on. And the other way is to say it's very bad or not bad. I think that's sometimes the easiest way to actually communicate, because if you've got displacement and you've got neurological injury, and that's bad. And if you haven't got those things, then that's not bad. And I think that is the very least you can do. But classification is probably a better way. Yeah. What do you like to hear on the phone, Monty?
As little as possible. No, so I think, as you know, the Denise classification has been overtaken by the thoracolumbar classification score. But I think for a general orthopod and an A&E doctor, still the 1 column, 2 column, 3 column is still quite useful. I think the TLIX, if you're on the spine team, the thoracolumbar classification system is useful in kind of guiding you as to whether a patient might need surgery or not. But I think descriptively, if someone can describe a fracture, it's a burst fracture, which is segmental kyphosis, and there's retropulsion of, the bone elements into the spinal canal, and, the pedicle is fractured. I think a good description is better than anything.
Some classification systems just work and they don't get better, like Shatska. Shatska is still a great way of describing the proximal tibia. There have been lots of evolutions of classifying thoracolumbar fractures, and I still think very few are better than Denis. I'd really encourage people to still think about the 3 columns, but the AO classification is actually one of those AO classifications that actually works for me. It's very simple. It's compression, it's distraction, and it's translation. And if you Google it, it's really easy to remember, and most people will understand it. So I think I'd recommend Denis and AO. They're they're classics.
Yeah, I agree. The AO has those three categories, but then there's all the subcategories. I think you just need to ignore, right?
Yeah, that needs a bit of thinking through. Yeah.
Yeah. Dave, I mean, ankylosing spondylitis, we kind of touched on it. I mean, that's a different beast, right? Why is that so different?
Yeah, so I mean, I think the classic is actually especially the cervical spine more than anything, is that we still hear stories of where a patient, an ankle patient, has a fall, and somebody puts him in a collar straight away, and he was neurologically intact, and then suddenly they're paralysed. So I think the key is that these patients, they have, well, as you know, bamboo spines. It's rigid. They're used to being kyphotic. They're used to looking down. So actually, don't strap them down. Just make sure you keep them in a stable position so that you can get some imaging. Listen to the patient. They'll be in pain. There's something not right. They're very, very high risk of having a fracture. So usually you need a CT, quite often you need an MR, but you don't want to straighten them out, if you see what I mean. You want to put them in the position they're used to being in.
Yeah, my takeaway with Ankspon for our trainees is, if you have an Ankspon patient who has a fall, who has new onset axial pain, they have a fracture. If the X-ray is normal, they have a fracture. If the CT is normal, they have a fracture. The MRI will show the fracture. And if it doesn't, then I'm wrong. But the thing is, the index of suspicion has got to be there. And if you miss them, they often show up months later having had pain, and worse, they might have displaced in the interim. They're very challenging fractures to fix. They need long lever arm fixation.
No, exactly. And also morbidity and mortality with delay in treatment is pretty high as well. And it's not just the operation, it's actually the transfer, isn't it? Transferring the tape is pretty good.
Very difficult.
So another question from, I'm going to direct it at Pete, actually, pelvic surgeon extraordinaire. So there's a question from the panelists about, how do you fix, what do you do with an S1 and S2 fracture?
And with an S1, S2, so that's a spinopelvic dissociation. So I don't think of it as a sacral fracture. Think of it as spinopelvic dissociation. So the fracture line goes down. It looks like on the axial CT. Sometimes it just looks like an LC1 fracture, where it just goes straight down through what one ala. Except with a spinopelvic, it's bilateral. So you have a fracture line down both sacral alar. So bilateral. If you see a bilateral LC1, it's almost certainly either U-shaped or H-shaped spinopelvic dissociation, and they can happen in the elderly. So you can get these like insufficiency fractures. Little old lady who just falls on her bum, and she gets that kind of fracture pattern. Now, because the ligaments are intact, it's a bit like an LC1 in the sense it's stable, can go non-operative, exactly like Leonard was telling us about the other fragility fractures. But in the high energy setting, then I totally agree. It's a multidisciplinary approach. It's like your spine guys help you with the spine bit, and the pelvic guys help you with the pelvic bit. And sometimes, there's quite a bit of discussion between us, isn't there, Monty? And getting two specialty together, there's never more fun surgery to be had than when you're operating with some of your buddies, with some of your other consultants from other specialties.
Yeah. And then there's a fight as to who puts their screws in first, because whoever has second, it's a harder job, right? Because the other screws are in the way. So we started off putting spine screws first. And then
I'll be really quick.
A question for you both, Monty and Pete. Are most of the ones that you treat jumpers or people who get in front of tubes? What's the mortality in the cohort that you've treated?
They're mostly jumpers, aren't they, Pete? A lot of them have multiple injuries. But yeah, we do get isolated ones as well. It really depends when you get it as well, because I think people agree there's a big difference between getting it straight away and getting it 3 days later.
Yep.
And your ability to reduce it closed. Pete did it, but we published this technique which Pete came up with to reduce it closed. And I think people agree that to do that close at 72 hours and longer is quite a difficult I think when you get it acutely, it's a bit easier. Wouldn't you agree?
Yeah, that's definitely the case in all pelvic fractures is that, you know, in that first 48, 72 hours, something happens and it all glues down, and suddenly what was lovely and compliant and wants to reduce, suddenly it's quite happy being where it is and it doesn't want to reduce. So spinopelvics, yeah, we make a point of trying to get to them as quickly as possible, because then you can do a like traction on the legs and a hyperextension maneuver, because usually if this is your sort of your normal curve of your sacrum, it tends to bend into kyphosis. So a hyperextension maneuver brings it out, and then you can apply your spinopelvic hardware to fix it in that position. But it only works if you get to them quickly.
Yeah, exactly. And David, I mean, were we right to you know, centralize all major trauma to the sort of MTCs, major trauma centers, or you know, should really everyone be getting a bit of experience in this?
No, I mean, I think it depends how you look at it. So there's too much just spine trauma, if you see. I mean, there's a lot of other spinal stuff out there. So I think the MTC stuff with multiple injuries, etc., needs to go. The major things need to go to the MTCs. But there is a lot of isolated spinal fractures, spinal emergencies out there, which can still go to the spinal hub centres. Now, the way, obviously, one of my roles are in commissioning, the spinal hub centres are commissioned, is they should work closely with the MTCs, do the stuff which is safe for them, which is a lot of these spinal, basically spinal fractures on their own, and other things like cauda equina, acute cervical stuff, and things like that as well.
Monty, can I ask you a question about high energy trauma around the thoracolumbar spine? What makes you do something percutaneous versus open? I've never quite understood how you make that differentiation between the two.
Yeah, probably because we don't either. No, I was joking. I mean, really, so most of them we do percutaneously because you know, we've shown that with most of them we can reduce them percutaneously. If you need to do a decompression, so if the patient has neurology, you might need to open it. Saying that, what I've done, if say there's a long fixation that we're having to do, you can still do it percutaneously, and you can make a mini open incision. So that's one thing. But occasionally you do have to open it. Most of the time we do it percutaneously. If you have a spinal cord injured patient, you don't want to go back in there again. So there's a big difference here. We haven't really touched on it between stabilization and fusion. Stabilization is you put the scaffolding in percutaneously. Fusion is you opening it, you're decorticating and burring bone and putting bone graft in. The downside of the percutaneous stabilization is that you may have to take the metalwork out. They may have issues with metal later. So if you have a spinal cord injured patient who is going for rehab, they don't want any other surgery, they just need stability, they don't care about the scar. You open them up, you burr everything, you burr the hell out of all the bone, you put some bone graft in and you fuse them. But otherwise, most of the time, we can do it percutaneously. And I think over time, I've developed a way of doing it percutaneously and doing mini open incisions and decompressions. So I'd say 95% of the time we do it percutaneously.
Yeah. And I would also agree with David about the major trauma thing, is because when you have high energy trauma, it always comes with other stuff, you know, and it's not just orthopedics. It's like, you know, they've got head injuries, they've got max fac stuff, they've got foot and ankle, they've got horrible feet are broken, and there's always a bunch of other stuff. And so that sits very comfortably in the MTC setting, and it really, these other things get neglected otherwise if you're in a place where that stuff isn't like standard fare. So I agree with that. Yeah,
exactly. And there's also the thing that, you know, a fracture that you might say, well, that could go in the brace. He's got rib fractures, he's had his spleen taken out, and he's got a pelvic fracture. I mean, this guy's not going to be very happy with you if you put him in a brace. You know, a quick percutaneous fixation, you know, I think, you know, risk of, you know, pros versus cons and everything, but it might be warranted in that patient. You might have put him in the brace, you know, with all those other injuries. So there's a number of other factors you take into consideration in the major trauma, and that might be one of them. So, yeah. Is there anything else arising, guys? Anything else? We've overrun our time a bit, but I'd like to really get this wrapped up before 10 o'clock. Is there anything else to say? No, I think we've said everything we can say. This is the stage of proceedings where I now do an abomination of the previous webinar, and I try and summarize in my own terrible way what's been said. So guys, I apologize for what I'm about to say.
First of all, David spoke to us about back pain. Great talk. Like, what a miserable talk to have to give. And yet he gave it like beautifully and explained it really, really nicely. Defining where you think the back pain's coming from and there's loads of places it can be coming from. And is it acute or chronic? So defining it is critical. We talked about things you should rule out when you're taking a history, back pain history. You're ruling stuff out, ruling out red flags, pathology, neurology, infection, etc. And then once you've ruled out those things, once you're happy this isn't something dangerous, actually how you manage the patient then is really critical. Like your reassurance, your signposting to other teams, the way you talk them through their scans and you show them, you say, this is where the problem is. And your cons to the patient are critical. Taking a good history, as always, in anything in life, in medicine, is critical. Checking that, and the stuff related to back pain that helps you rule out those other things. Checking the medical records, any recent trauma, things that might hint towards infection and tumor. Remembering that tumors don't always happen to old people; they can happen to. We had a 34-year-old with myeloma. Being alive to non-spinal causes. We talked about pancreatitis, we talked about vascular insufficiency, mimicking spinal problems, multiple admissions for the same back pain. Something's going on. It's like multiple issues. Something is going on here. Maybe they're known to the pain team, or maybe there is a red flag, but no one's actually quite picked it out yet. And I love the fact that you say, yeah, blood tests are useful, but X-rays are not. And even a CT, we're being told, isn't particularly helpful in that acute setting. If you're going to get anything, get an MRI. It came up in 2 talks, this, about the PR and the pre-post bladder scan. And I'll come back to that in a minute. Examining the hip, limb length discrepancy, some kind of spinal deformity, sagittal balance, coronal balance. Is there a reason for this back pain? And this is the thing I was mentioning earlier, comms with the patient. Take them through their images. Avoid alarming terms like, oh, you've got a fragmented disc, or your spine is crumbling, or all these hysterical terms that patients hold on to, and they come back like a year later and they say, I was told that my spine was crumbling, and they never get over it. The killer one is, what is a red flag? Boom, if you're going to take a screenshot, take it now. Bang, there we go. There are your red flags of back pain. I'm not going to read them out, but there they are. Screenshot it, done. Hanny gave us a nice one on nerves, nerve entrapment. Remember, the cervical ones go over the top, lumbar ones thoracolumbar go underneath, and that's why you have C8. There's no C8, you've got this funny nerve root C8, which kind of doesn't fit anywhere, but that's where it comes from, because those go over and those go under. Nerve pain is bad. Peripheral nerve pain is bad. Traversing, exiting. Remember, exiting is the one coming out. Traversing is the one that's about to come out. He's the one who's coming out below. And when a disc pops out, it usually pops out just not to squeeze the one that's exiting at that level, but the one that's lining up to exit at the level below. So an L4-5 disc will hit your L5 nerve root. I've got that right, haven't I? Unless, of course, it's a far lateral disc, in which, yes, it will catch that one that's exiting. So it's not always the same, but by and large. Peripheral nerves cause pain and dysfunction. We talked about the Asia scoring, which is like a nice way of standardized things, great for communications, but obviously it is a bit of an oversimplification, and it doesn't account for variation, but it's a nice way to communicate. And it's also a nice way to document people's progression over time, because you're always documenting the same thing. Upper motor neurons are different from lower. They don't always cause pain. So you can have you can just go floppy. You don't necessarily cause pain. You get positive and negative signs. Remember, the positive ones are those hyperreflexia, spasticity, clonus. Yeah, that was a beautiful one. I love it. And then you have negative signs, which are the weakness, loss of coordination. I can't stand up properly. My legs feel all wobbly. That side of it. I can't do these things with my hands anymore. Positive and negative signs, beautifully described. And then the urgency, of course. Urgency for decompressing a nerve sits really around progressive motor loss and acute caudal equina. Don't ignore urinary symptoms. If someone's got urinary symptoms, they're having a little bit of leakage or whatever, that has to be a diagnosis. And it doesn't have to be spine. It could be a bunch of other things, but you've got to walk away with the diagnosis. You can't just ignore it. There you go. There's your screenshot of the red flags for caudal equina, very similar to the previous one. Remember the difference between CESI, incomplete, and CESR, R standing for retention, yeah? Painless urinary retention. So basically their bladder fills up, but they don't really feel it. And then they get overflow symptoms, yeah? And so that's what the post-void business is about. So, and actually, wasn't it interesting from our faculty, the PR, okay, do a PR and document it, great. But the fact of the matter is it's a bullshit test, because usually it's done by ED doctors who've hardly ever done done a PR on a patient who's got no voluntary squeeze. They don't know what they're feeling for. They just, actually a post-void residual is probably a much sharper tool, and that was my take home on that one. So I'm not saying don't do a PR, but definitely document it, and don't stop there. A PR that you think is okay may be misleading you. Don't be reassured by that. That was the take home. Lenore gave us a great one on spine trauma. I'm almost done, guys. He drew a really important difference between the energy of the injury, high versus low, and the demographic of the patient, elderly versus young. In the neck, I love it. X-rays are rarely useful. CT is the imaging of choice. So anyone's got neck pain, if you want to rule something out, they're getting a CT. Geriatric peg fractures equal a hip fracture. Beautiful, huh? Nice analogy. Lenore, it was really nicely described. I love your analogies. It's great. Halo, no. Aspen collar, yes. So it's non-op, but it's something that allows you to move around. But remember that geriatric peg group, they are a bit like hip fractures in their mortality. This is a life-threatening injury or a sign of impending death for a lot of patients. Younger patients with peg fractures is higher energy. You're fixing those. Thoracic, lovely bridging construct analogy with a transverse, bridging femur fracture. Thoracolumbar, low energy. The low energy injuries, they can go non-op. You don't necessarily need a brace, but you do need bone protection. And some people, yes, you can stuff cement into it, but bisphosphonates, don't forget that fracture liaison side of any fragility fracture. High energy, those are the chances, those are the ones, you just get it from the history, it's always there. One of the take homes there was always do a PR. Even if their legs are working, do a PR, because he might have caught the equina and left the legs intact. Lumbosacral, or the spina pelvics, again, it's multidisciplinary sport, and it's usually sits in major trauma centers, usually from jumpers, but it can be from like trains and stuff like that. Brilliant. And that was the take home from Lenore's talk. That if there's one take home, there it is, right there. Guys, I hope I haven't misrepresented your talks terribly.
Brilliant.
Can I say one more sincere thank you to Striker Spine for sponsoring this webinar. We couldn't do without you guys. We can't continue this and keep it free for everyone without that. I'm going to wrap it up there. Thank you very much, guys. So grateful to the faculty and 3 brilliant talks, and Monty superbly chaired. Thank you very much, guys. Really good.
Thank you. Thanks for having me.
Very much.
Cheers, Pete.
Cheers, guys.